Hello everyone, my name is Sonia from Rotterdam Ophthalmic Institute. This presentation shares the results of one of 10 AGI PhD projects under Marie Curie Initial Training Network. This project studied the intraocular scattering changes with age in human eye. When you drive at night, you may experience being temporarily blinded by the headlights of an oncoming car. This may also happen when looking at low sun. Inhomogeneities in the ocular media can cause the entering light into the eye scatter, resulting in a veil of light called stray light projected onto the retinal image. We know that disturbances to the eye media may cause vision loss of a small detail. This is clinically assessed using a visual acuity letter chart, but eye media disturbance can do much more harm because it may cause light scattering, resulting, as said, a veil of stray light over the retinal image. An individual who experiences stray light may complain about hazy vision, loss of contrast and color, increased glare hindrance, and so on. In an ideal eye, there would be zero light scattering, but the eye media are not optically ideal, so there will always be some light scattering, which reduces the contrast of the retinal image, causing a decrease in the quality of vision. In short, the more the inhomogeneities in the ocular media, the more stray light. And the more stray light, the worse the vision would be. Among various components of the eye optical media, cornea and the lens together produce almost 2/3 of the scattered light. Corneal light scatter is more or less constant with age, but may increase as an unwanted side effect of refractive surgery. The lenticular contribution, however, changes with age because the lens changes with age. The lens grows over time, and its color changes from clear to milky to yellow and then brown in eyes over 65 years of age. An old lens, even the clearest one, is a substantial source of stray light. Several studies have confirmed that a stray light increases with age, predominantly due to the changes in the lens, even in normal eyes. We know even in young healthy eyes, a small part of the entering light, almost 10%, is scattered. Because the eye media are not optically ideal, there will always be some part of light scattered. Apart from the aging factor, some pathological conditions such as cataract increase stray light. Cataracts, as the leading cause of blindness, are of our interest. The prevalence of cataract increases with age. Statistics from National Eye Institute of Health in America in 2010 show that the percentage of population with cataracts jumped more than fourfolds from age of 60 to 80 years. About 285 million people are visually impaired worldwide. 39 million are blind and 246 million have low vision. 4 out of 5 suffer from blindness or visual impairments, which are avoidable. 65% are visually impaired and 82% of blind people are over 50 years of age. Top causes of visual impairment are refractive errors and cataracts, whereas the top causes of blindness are cataracts, followed by glaucoma and age-related macular degeneration. Individuals with increased stray light due to cataract may complain about hazy vision, loss of contrast and color. These problems are much enhanced if visual function is already low from retinal pathology such as macular degeneration or glaucoma. Due to prevalence of cataract worldwide, cataract surgeries became widespread. Cataract surgery and intraocular lens implantation have taken on many significant advances since the earliest inception. As the age population grows, the number of cataract operations also increases year on year. Globally, 8.7 million cataract operations are performed per year. technical advances are occurring ever more rapidly, enabling improved preoperative assessment and surgical management. Consequently, both patient and doctors have higher visual expectations. The expectation is now that the operation will achieve more than only removal of a pathological opacity. The expectation is that the procedure will be tailored specifically to the patient in such a way that it optimizes the optical system to restore vision to a great extent. Optimization of any particular optical system and process can be complex. An ocular optical system, as well as cataract surgery, are no exception. The decision-making process in determining whether and how an individual eye should be surgically customized can therefore be complicated. But having said that, the question is, what are the factors in current cataract surgical decision-making process? Despite all the technical advancements, the decision-making process for cataract surgery still has a traditional framework, encompassing only subjective factors, which includes visual acuity tests, slit-lamp lens check, and patient's complaints. What are the disadvantages of applying the current cataract surgical decision-making system? In most cases, cataract removal and IOL implantation succeed in lowering intraocular stray light. However, up to 18% of cataract patients experience increase or no improvement in stray light after the surgery. The figure on the left shows that the relationship between the preoperative stray light value and its improvement after IOL implantation was different in the various age groups. The upper lines and the lower lines correspond to the age ranges 40 to 50 years and 80 to 90 years, respectively. This suggests that the older the patient is, the more preoperative stray light is required to achieve postoperative improvement. The figure on the right shows that 10% of pseudophakic patients suffer from debilitating stray light elevation. These two graphs prove the predictability of the cataract surgical outcome and a clear relation between pre- and postoperative stray lights. To overcome this deficiency in the decision-making process, there needs to be an alternative or substitution. For this reason, we need to identify and employ variables which are objectively measurable. We may add these variables to the current algorithm or employ them as surrogates. The main interest of this work, however, was to study the changes in the amount of scattered light in the aging eyes with a primary focus on cataract eyes. To this end, we set out our objectives as follows. First, we studied the in vivo stray light of aging eyes. We also tested the possibility of using certain optical functions and cataract morphology as objective variables in more desired cataract surgical decision-making algorithm in the future. Our objectives called for an understanding of functional effect of cataract on vision. The quality of the retinal image is limited by the optical imperfections. In practice, the quality of the image is assessed by determining the amount of light being spread across the retina, which is called point spread function. The point spread function describes the response of an imaging system to a point source or point object. The central portion of the point spread function up to 0.3 degrees is affected by optical aberrations. In clinical practice, it is the small angle domain that is assessed by visual acuity test, contrast sensitivity, and wavefront aberrometry. By assessing ocular wavefront aberrations, important information can be obtained. The outer skirt of the point spread function is caused by light scatter and known as stray light, as said before. Stray light does not contribute to visual acuity and higher order aberrations. Studies have shown that there is in fact very weak correlation between stray light and visual acuity. They explain this event by pointing out that the process of light scatter, which results in a stray light, has little impact on the central region of the point spread function, which is associated with visual acuity regardless of the level in terms of severity of stray light. Stray light is measured by Sequent, a commercial instrument to evaluate intraocular scattering. The compensation comparison method used in this instrument is based on direct compensation method. The amount of a stray light is expressed by a single number called stray light parameter, which is in fact the ratio between the undesired scattered light and the desired non-scattered light, which forms the retinal image. This parameter is calculated by the formula shown here. The sequence gives the parameter in logarithmic scale. As said earlier, the central portion of the point spread function is affected by optical aberrations. Optical aberrations of the eye limit the quality of the retinal image and constrain spatial vision by decreasing acuity and contrast. Commercial aberrometers describe different aberrations by Zernike polynomials. Each polynomial corresponds with an optical aberration. Higher order aberrations have been reported in form of root mean squared, stray ratio, as well as Zernike terms. However, several studies have shown that these metrics do not properly reflect the visual performance of the eye. One publication demonstrated the correlation between 31 image quality metrics and visual performance. Further studies showed that a family of 3 aberration-derived image quality metrics had the highest correlation with visual acuity. These metrics are called visual stray ratio metrics. The sharpness of the point spread function is computed by multiplying the point spread function by a neural weighting function and summing the result. The visual stray is computed in a similar way, only that it uses a neural weighting function derived from the human contrast sensitivity function for interference ranges. This metric can be calculated in frequency and spatial domains. In this work, we have used the one calculated in frequency domain using modulation transfer function, therefore is called VSMTF for short. So, what have we done in order to study the change in stray light with age and identifying further potential objective measures to complete or replace with the current measures used in making decision for cataract surgery? Previously, the effect of pupil size on stray light has been studied. It might be thought that stray light is more bothersome at night, on the grounds that a larger pupil allows more light in the eye, causing more glare. Therefore, the amount of stray light changes under low environmental light intensity. However, one should consider the fact that as the amount of scattered light increases by the enlarged pupil, the amount of constructive light entering the eye also increases. In other words, the ratio between the destructive and constructive light remains constant. One study concluded that the amount of stray light measured in a small group of predominantly young subjects with normal eyes only weakly depended on pupil diameter. Therefore, stray light values obtained in healthy young eyes under photonic conditions are valid for mesopic and scotopic conditions as well. In this part of our work, we wanted to find out what the pupillary conditions are during stray light measurement and what potential effect this might have on the measured stray light values. In other words, we investigated whether pupil size and stray light measured under the dim room light conditions is the same as pupil size and stray light measured under dark room lit condition. So we set out 2 objectives: to study the change in pupil diameter as a reference for the next part, and the change in stray light under various room illuminances. For this purpose, we included young and elderly individuals with normal eyes. In the second part of this work, we sought out for another suitable objective measure for predicting visual performance. As said previously, several studies confirmed the strength of a family of image quality metrics called visual stray ratio in predicting visual performance in normal or non-cataract eyes. One study showed that a constant root mean square of wavefront aberrations of 0.25 micrometer over a 6 millimeter pupil could shift visual acuity by 2 lines on a logmark chart. It was also shown that specifics of combinations of Zernike modes can be important, even more important than the magnitude of each individual mode. The magnitude of the loss was dependent on which aberration modes were combined and in what ratio. The best visual steroid ratio metric was reported to account for 81% of the variance in high contrast logmark acuity in normal and non-cataract eyes, and was shown by the original authors to be an accurate predictor of visual acuity. Several other studies also confirmed that there is a strong correlation between visual steroid ratio metrics and visual acuity. So we aim to test the usability of one of the visual steroid ratio metrics in quantifying the impact of cataract on visual acuity. Accordingly, we studied the correlation between this metric and visual acuity in cataract eyes with uncorrected vision and compared the results with that of normal eyes. We then furthered with estimating the correlation between this metric and visual acuity in cataract eyes after correcting their lower order aberrations. As mentioned earlier, visual acuity is an important criterion in the cataract surgical decision-making process. However, various studies have shown that in a significant number of cataract cases, visual acuity is not an adequate measure to judge visual performance. Later, other studies have supported this notion. Moreover, there have been reports of no change or even an increase in stray light after cataract surgery, when the decision was made only based on visual acuity. The reason for this is that the visual acuity only evaluates the impact of narrow angle light spreading due to refractive errors, and therefore it can only measure a limited part of a patient's vision. Another study concluded that additional visual tests were needed that could measure visual loss, but at the same time should be unrelated to visual acuity. They acknowledged the direct compensation method to quantify stray light as a standard technique to evaluate the validity of disability glare tests. Recently, a literature review established a norm curve for pseudophakic eyes, also a reference curve to estimate the amount of stray light to be expected after cataract surgery by introducing stray light improvement as a function of age and preoperative stray light. Although this reference is a good measure for cataract management in an average eye, it may overlook the influence of the type, location, and intensity of the cataract, and not the outcome of the surgery, because the type of cataract was not specified in the norm curve. Therefore, we need to establish morphologically stratified phakic references. In this part of the thesis, we performed a literature review to identify relevant papers which contain data on stray light, age, and visual acuity in 3 common types of cataract. In addition, we recalculated the significance of the relation between stray light and visual acuity with taking cataract morphology into account. The published studies included in this literature review evidenced individually that such correlation varies from one type of cataract to another. The population sizes and severities of the cataracts were different across these studies. We considered the relatively large final number of observations and their diverse degrees of cataract intensity as the strength of this study to improve the generalizability of the results. The last part of this work was a case study on congenital cataract. Congenital cataract is less prevalent, but it is responsible for approximately 10% of childhood blindness on a global scale. The most common causes of this type of cataract are genetic mutation and infection during pregnancy. Congenital cataracts are non-progressive and rarely affect acuity, but since they have their light obstructive nature, they cause various amounts of backward and forward light scattering. It has been proved that stray light intensity decreases greatly with angle, with an approximately quadratic dependence. the straight light parameter changes slightly from 2.5 degree to 25.4 degree with a parabolic behavior with a minimum around 7 degrees in healthy as well as cataract eyes. We had come across 3 young cases with pulmoral and congenital cataract. Both eyes of 3 of them demonstrated highly elevated, all the while their visual acuities were absolutely normal. The standard straight light at 7 degrees was measured for both eyes of the 3 individuals. However, only one of them agreed to continue with the rest of the study. We were interested to find out the angular dependence of a straight light in pulmoral and congenital cataract. We also studied the previously mentioned image quality metric and cataract morphology in this case, and compared them with those of previous studies on normal and cataract eyes. The first part of this work, we had aimed to find out the pupillary conditions during straight light measurement with the sequent, and the potential effect this might have on straight light in normal aging eyes. The outcomes led to the following conclusions. First, under both mesopic and scotopic conditions, the luminance of the test field is so much higher than that of the room that it is the brightness of the test field that determines the pupil size. Next, we found out that the illuminance of the examination room during straight light assessment does not affect the outcome. Eventually, we gathered, regardless of the lighting level, straight light measured in a laboratory applies to photopic pupils at an adaptation level corresponding with a daytime illuminated room. It seems probable that the same applies irrespective of eye condition, such as cataract. In the second part of the work, we tested the usability of the ocular visual straight ratio derived from wavefront aberrations for quantifying the severity of age-related cataract in terms of visual acuity. Therefore, we sought to study the following objectives. First, the correlation between the visual acuity and visual straight ratio in cataract eyes with uncorrected vision and compared the results with that of normal eyes. Next, the correlation between the 2 variables in corrected cataract eyes in terms of higher order aberrations. High correlations were found between the visual straight ratio and visual acuity in both uncorrected non-cataract and cataract eyes. This suggests that visual straight ratio may act as a surrogate for testing visual acuity in eyes with normal function in retina and cerebrum, regardless of their cataract status. The results of the cataract group after correction also corresponded with the earlier data. Therefore, we gathered that the visual straight ratio is a suitable metric for predicting visual acuity in both healthy and cataract eyes. Perhaps more interestingly, visual straight ratio can be used as an objective and independent measure for the severity of the cataract in terms of visual acuity. In the next part of the study, to establish a reference stratified to cataract morphology, which can predict the outcome of an operation in terms of straight light, we conducted a literature survey. In this part, meta-analysis and relevant published studies resulted in concluding that taking cataract morphology into account for weighing the dependency of a straight light on age and visual acuity will provide a more accurate insight into the visual dysfunction of cataract eyes. This is especially evident in eyes with posterior subcapsular cataract, where remarkably elevated straight light might not be accompanied by a notable loss in visual acuity. In the last part of this work, we found out that in pulmoral form of congenital cataract, a deteriorated straight light might not be accompanied by loss of visual acuity. We also found out that similar to age-related cataracts, this form of cataract too elevates the amount of light scattering in the eye. However, the straight light had a different angular dependence caused by the existence of particles which are much larger than those found in normal lenses and age-related cataracts. Thank you for watching, and I hope you found this video informative.